if we want to start.
Yeah, let's, okay, we'll get started with our proceedings. I'm Dr. Ravi Kohli. I hope you all can hear us well and see us clearly. And I'm the current president of AAPI, American Association of Physicians of Indian Origin, for those of the guests that are not very familiar with AAPI. And I want to thank all the members, especially from the West Coast, waking up early on a Sunday morning, including Pankaj, for being here. And today we have an important event and a webinar talking about lifestyle and obesity medicine from the topmost exponents of this topic, presidents of the both organizations. So it's my distinct honor and pleasure to invite you all to this webinar. And let me introduce my good friend Pankaj Viz. He's a MD, FACP, and a board certified internal medicine and obesity medicine and specialist who has been practicing lifestyle medicine in San Francisco Bay Area for a long time. And he's a former board member of American College of Lifestyle Medicine and the chief architect of the Crack the Wellness Code, a community health platform promoting mental health, all kinds of health style changes. And we are very proud and honored to be partner of Crack the Wellness Code. We had an MOU last year, and they did a lot of substantial number of events, participated at our convention last year as well. He's also a well-known TEDx speaker and has many of his recordings and available on YouTube and TED panel. He's also author of the bestseller Turbo Metabolism, 8 Weeks to New You, Preventing and Reversing Diabetes, Obesity, Heart Disease, and other metabolic diseases by treating the causes rather than just treating the illness. So I will invite Pankaj and for moderating the session today. And we also have, let me introduce Dr. Uma Koduri also, and then Pankaj will take over introducing the rest of the speakers as they come. Dr. Uma Koduri actually doesn't need any introduction to AAPI members. She has been a long-standing member and leader of AAPI in many health style choices and movements. For the sake of people who may be joining recently to AAPI, let me introduce her. She's a primary care physician at the Jack C. Montgomery VA Medical Center in Tulsa, Oklahoma. She is currently the Lifestyle Medicine Committee Chair and previously the founding chair of the Obesity Committee in 2013 of AAPI. She's also the founding president of the Tulsa AAPI chapter and has been a passionate advocate about healthy lifestyle choices and fighting obesity, and has done substantial number of programs with veterans, school children, and the community. And she also has a unique knack of finding dates to match events. She found a unique date of 11-11-11 and organized the first worldwide health walkathon, in which many of her friends and family members joined from 5 continents. And a year later, on 12-12-12, December 12, 2012, she organized the first ever obesity walkathon, promoting yellow for healthy lifestyles and obesity awareness. And she has done a lot of obesity walkathons and educational programs over 100 schools across the country in the USA with the support from AAPI grant. She also received grant from the VA Medical Center in 2014 and started the Obesity Walk for Veterans and became like a benchmark event for veterans walkathons ever since. Her most recent event was November 2022, as she was the steering committee member for the whole health program at her VA. And she has helped organize the first ever Veterans Week Whole Wealth Walk with the yellow theme. Her passion is promoting yellow as the kind of a symbolic color for, like many other illnesses have colors, right? The pink for the breast cancer and red for heart disease. Her passion is to promote yellow color to signify the all the substantial symbolic things that yellow stands for. She will talk about it more. So we wanted to do a proclamation also about she did the official proclamations in the past. That was officially declared by the governor of Oklahoma, governor of Georgia, several mayors, including Danville, Virginia, Tulsa, Oklahoma, Muskogee, Oklahoma, Garland, Irving, Plano, Texas, and also the Global Association of Physicians of Indian Origin. She's a recipient of Leadership Award from Global Association of Physicians of Indian Origin and a Trailblazer Award from Wheels Global Foundation. So without much further ado, I will ask Pankaj to moderate and probably Uma first to speak and then go from there to Pankaj to moderate the rest of the session. And I'll be staying tuned. And Dr. Malti is one of our moderators, and she'll also introduce other panelists as we start. Thank you so much, and go ahead, Pankaj. Go ahead, Uma Garu.
Yeah. Thank you very much, Dr. Ravi Garu, for the very kind introduction. And thank you all for joining us on this Sunday morning here in USA. I basically want to do a PowerPoint presentation, and I'm going to be very brief because I want the main speakers, Dr. Fitch and Dr. Fritz, to do the main talk for the CME. So can you see the first slide?
Not yet.
Oh.
So go to share screen on the bottom again. Share screen, the green button. Now go to your PowerPoint. Yes, okay. Perfect.
I don't, okay. So basically, AAPI for the last 10 or more years has done tremendous amount of work trying to educate the community, going to schools, in the wherever we could get a chance. This is what we were promoting, healthy lifestyles and how to fight obesity. Our guiding principle has been this: education is the most powerful weapon we can use to change the world. This and the next one from World Health Organization, which says that prevention is the most feasible option we have now. And our goal is to make the healthy choice the easy choice. We need to teach everybody how to eat healthy in the most, the easiest way. So towards that end, we were trying to do community events and walkathons and making it fun to make people remember what they learned. So this is one of the main logos that we created. If you see this particular, there is a 12 between 11. That's just to show that we started this campaign in 11, 11, 11, and then in 12, 12, 12, we changed it to basically obesity and the yellow color. The rainbow colors here, they represent that we need to eat colorful foods, which have all vitamins, minerals, and everything. Actually, every little part of this logo has a lot of meaning. Here it shows the father, the mother, the child, just to show that it's a family effort to lead healthy lifestyles. On 11, 11, 11, we started off with the green color for healthy lifestyles, for green environment, and that was the goal. That was what we wanted to promote. But a year later, we changed it to yellow because we wanted to focus on obesity. And yeah, this was our very first big event that we did in a school in 2013. And after this, AAPI organization gave us like $100,000 to do school events across the nation. And in 3 years, we covered more than 100 schools in USA across 15 states. AAPI physicians would go to their local schools, provide yellow T-shirts, provide educational material, talk to the principals so that they would set aside a couple of hours, actually half a day, so the kids would gain with these gain knowledge with these events. So this is the very first one. That's why I put the slide. And then and we even in India, we collaborated with the Global Association of Physicians of Indian Origin and started doing educational events for children in the schools in India. And so far, I think we covered about 12 schools or more. But after 2019, COVID happened, so we didn't do many events after that. And then our goal was to cover all the continents. So one of our AAPI presidents was nice enough to even do an event in Antarctica. So we basically covered all the 7 continents with these events. I just wanted to bring that point because the world map is in the logo that I showed you before, just to show that we want to educate everybody in the whole world in whichever country we can. And then this is just to show we got a lot of proclamations, official proclamations from governors, mayors, and all these big officials and organizations. And this one, yeah, I wanted to touch upon this. This is the whole health which the VA follows, the Veterans Organization. It is so similar to the lifestyle medicine logo which we have here, the 6 pillars. And then this is what AAPI had made a couple of years ago, which again is very similar to the others. And to tie in all this, we thought when we do events, we can just promote the color yellow. Then why yellow? Because yellow, it stands for, it's like sunshine yellow that we try to use. The banana yellow, it's a pretty yellow color. And then because yellow, it stands for energy, motivation, hope, optimism, joy, and happiness, which everybody wants. And then basically, that's in short what AAPI was trying to do all these 10 years and more. Thank you. And now I would like to introduce Dr. Malti Vich, who is going to introduce Dr. Angela Fitch. Dr. Malti Vich, she is the internist, weight loss and women health specialist at the University of Cincinnati.
Thank you, Uma.
Yeah.
Can you hear me? Yeah. Hi, good morning, everyone. I want to thank you all for joining us today for this wonderful, exciting webinar. And I'm sure you all are in for a treat today because we have 2 excellent speakers. And I will be introducing one of them, Dr. Angela Fitch. Dr. Fitch, she is a leader in the field of obesity medicine. She's the current president of Obesity Medicine Association. Personally, she's a good friend and a mentor, and I know her leadership skills since she was at University of Cincinnati. She helped us build up a multidisciplinary weight loss center from a scratch, and she was the vice president of Primary Care Network, where she was managing over 19 primary care clinics and managing like over $1 million in budget. And because of all her efforts in obesity field, she has earned a lot of awards and recognitions. Just to mention a few, she is the winner of 2017 Clinician of the Year Award for AMA. She served as chair of the clinical management section of the obesity section in 2015-2016. She's a board member of the Obesity Action Coalition and a founding member of the Massachusetts Coalition for Action on Obesity. She's faculty of medicine at Harvard University. And before coming to known well, she was the associate director of Mass General Weight Management Center. She's board certified in obesity medicine, internal medicine, and pediatrics. And her mission and passion is to help patients suffering from chronic disease of obesity receive easy access to care without stigma or bias. Without further ado, I'm going to hand it over to Angela. Take it from there.
Thank you, Dr. Vij. I'm just getting my screen up here just a second. You'd think after so many years, this would be really easy. Let me start my presentation first, because otherwise I end up sharing the wrong screen.
And while you're getting set up, I'll just remind everybody to post their questions in the Q&A. We'll have a robust session Q&A at the end with Dr. Freites and Dr. Fitch.
All right, thank you so much. Yes, please, more questions, the better. And I'll try to go through this, expeditiously so we can get to Dr. Freites as well and have time for questions. As Dr. Vij mentioned, I'm now the Chief Medical Officer and co-founder of a new clinic model called Known Well. You can find more information on our website if you're interested. Oops. There we go. As you all are probably quite aware, obesity is a serious treatable chronic disease. And we highlight these words serious, chronic, and treatable because it is all of these things, right? Anymore now in 2023 with the levels of treatment that we have for obesity, it's no longer okay just to sort of say, you have obesity, there's nothing we can do, right? I mean, it's a time, a new time and a new era, and we want to move forward with chronic disease management of this important disease. As you know, it's really a disease of excess body fat that's accumulated in a dysfunctional manner to a level that may have adverse effect on health. You will notice that in that definition, there's no mention of anybody's weight, because what it really is about is excess adiposity. And that's what we're really trying to educate clinicians on, especially, and patients, that this is ultimately about biology and not just about a number called the BMI. We use BMI as a screening tool, to make an appropriate diagnosis. But as all of you are aware, BMI is not an absolute diagnostic obesity defining number, right? And BMI is complicated, especially in different races and ethnicities, as to its effect on metabolic disease. So while it's used to sort of screen for the severity of the disease of obesity today, I think in the future, we will look more importantly at body composition and other variables, such as looking at the level of adiposity in order to make a more consistent diagnosis as it relates to the effect on health related to this adiposity. Many other diseases are treated in a comprehensive chronic disease-based fashion. For example, cardiovascular disease, you have primary care clinicians, cardiology, interventional cardiology, and cardiac surgery, all working together to optimally make recommendations for treatment, because that's going to provide the patient the best outcome. Same with cancer. We have sort of an integrated treatment approach across all cancer centers. Unfortunately, today with obesity, it seems to be very disjointed care that lives in silos. There's bariatric surgery, there's obesity medicine, there's primary care, and people are doing different things, but ultimately we'd like to get everybody working together at the top of their licensure to be able to deliver the most effective treatment for that patient who needs it. The goals of treatment are what we really want to look at when we're looking at discussing treatment with a patient, right? Because we know that if you look at this, this is a picture from an article that Dr. Garvey wrote not too long ago about the idea that when we really get into this 10 to 20 to even 25% weight loss, this gray area here behind this graph, this is where most of the action happens, right? If you look at 15 to 20% weight loss, this is where type 2 diabetes goes into remission. This is a cardiovascular risk reduction that happens in this 20 to 25% weight loss, which is the weight loss that we get from surgery. So a lot of our data comes from our data from bariatric surgery that looks at a cancer risk reduction, cardiovascular risk reduction, as it relates to that 20% weight loss. And you can see this gray represents semaglutide 2.4 milligrams and second generation obesity medications, because this is our newer area of medication management, tends to help patients get into this 20% weight loss category even more, where a lot of these sort of significant disease risk modifications or complications of obesity are treated. So the idea of comprehensive care should be based just like on any other chronic disease, as I mentioned. As if we look here on the left-hand side, as we have increasing health risks, increasing complications of obesity, and increasing adiposity, we have to increase our treatment intensity if we're going to accomplish a different result. So again, this is about treatment intensity and matching that treatment intensity with the disease burden. It's not about the fact that someone failed lifestyle modification or failed pharmacotherapy and therefore needs surgery. This is about sort of risk stratifying for a patient, what their specific disease treatment is going to be, what's going to be best for them to accomplish their goal. Because as you can see on the right-hand side of this pyramid, these are the amounts of weight loss on average that come with these interventions. If a patient needs a 30% weight loss in order to have a kidney transplant, for example, it is unlikely that they are going to accomplish that with a lifestyle treatment by itself. That's just the data around the effects of lifestyle modification. It doesn't mean that any one of these things are not as important as the other, because the idea is they're all important for optimal outcomes, and we have to quit sort of using them, so to speak, in silos, but use them across the whole treatment, which is what this sort of entails, that really it's not so much a pyramid of treatment, but more a pillar of treatment, as you mentioned earlier in your the pillars of lifestyle medicine and the pillars of obesity medicine that we have as well. We all have these pillars because patients move actually this way across the pillars versus sort of up and down, sort of climbing the pyramid. And when we're talking about, how do we treat obesity, others have started talking about these sort of 3 Ds of assessing and diagnosing obesity. First is a discussion. Bring up the matter of weight and weight management and interactions in a sympathetic and an empathetic way. The idea is that weight has been very stigmatizing to people for a long period of time. So we have to be aware that patients have a lot of trauma, and in a trauma-informed care, bring up the idea that their weight may be affecting their health, and how can we make that different? And then make a diagnosis, communicate the diagnosis to the patient, that we think that this is an important diagnosis, not because it is a moral failure on their part, but because it's important diagnosis because we want to try to follow it, and we want to try to make it better over time. And then most importantly, provide the direction they need and the guidance, and schedule follow-up appointments specifically around weight management and obesity treatment, not specifically just to say to patients, well, try this, and if it doesn't work, come back and see me. That's sort of been the sort of way it's been delivered for quite some time. And patients don't come back, frankly, because a lot of times they're embarrassed. They feel, again, that it's been a moral failure on their part when they're living in an obesogenic environment and they are having trouble, changing that environment for themselves. That's a very challenging thing to do. But really having that scheduled follow-up appointment is critical to let them know that no matter what happens, you want to see them back so that you can monitor their disease. We're also really talking today about decreasing stigma and bias around obesity by using better language in our discussion. For example, we don't say that this is a cancerous patient. And so no longer should we say this is an obese patient, because patients are not defined by their disease state. So again, we have a patient with cancer, we have a patient with obesity. So we're getting rid of words like obese in our language, or try and get rid of those terms, and using more, less stigmatizing terms as it relates to the disease state overall. What we really want to do too is emphasize shared decision-making. When we're talking about treatment with patients, the idea is to have a shared decision-making discussion. This is my issue that I'm dealing with as a patient, and this is, and as a clinician, you're educating people on what that is and what the health risks of their disease are. And then really exploring with the whole team of clinicians, whether that's a dietitian, a health coach, whoever that might be, the preferences regarding the harms, benefits, and potential outcomes of treatment, and what are those risks and benefits of treating it versus not treating it. And then having an interactive process, around what that subsequent treatment or testing plan should be. This is the basis of shared decision-making. And to sort of highlight that, for example, you might have a patient, as we discussed, that needs a greater than 20% weight loss in order to have something like a kidney transplant. And you can see here that that would likely favor the patient to undergo surgery as the most effective treatment, the most likely treatment, and we'll see in a slide in a second why I say that, the most likely treatment to get that patient to that goal. And so again, looking at the different needs of patients and what might get them to that goal is really what we need to do, as we move forward in the future. If we have a patient with no complication of obesity down here, and they just want to lose weight for whatever reason, for prevention, for feeling better, for moving a little better, that likely would favor a lifestyle intervention as the first intervention because they don't have complications of obesity. Their disease burden is not that great that they need maybe this aggressive treatment such as surgery from the first initial encounter. So again, looking at that shared decision making is really what we'd like to sort of move forward with in the future as we combine treatment across those pillars as we discussed. So this was a patient, just an example of shared decision making. This is about way back in 2011. She did a very restrictive diet, a very intensive, probably unhealthy, so to speak, restrictive dieting pattern, diet mentality, was, exercising a lot, and essentially really struggled to maintain that as she sort of regained weight here over the course of, you can see this is 2012, it's kind of small at the bottom. And this is all the way now, in 2018 when she came in to see me. So over the course of this 5 years, her weight slowly came back on because she had trouble, maintaining this very sort of intensive lifestyle intervention that she undertook. Now you can see the good news is she's certainly also not back where she was before. So while these efforts may have been too intensive for her to maintain, she has sort of, at least her efforts have produced some weight loss over the course of time, which is certainly good versus this weight where had she not entertained any intervention here, her weight would likely continue to go up and she would have been much higher. So here she started on liraglutide. She lost some weight right about here. She started on naltrexone and bupropion as well to try to promote more weight loss, which she did get here and went down to here. She plateaued at this sort of BMI of 30, which was a weight around 160. And we also added Gelesis 100 at that time to try to see if that would help her. You can see she sort of oscillated around some weight loss, some weight gain, some weight loss, some weight gain. And here is where semaglutide came to the market. And she was switched over to semaglutide and actually was able to come off, obviously, her liraglutide. She came off her naltrexone bupropion and her Gelesis and was only on semaglutide at that point. She continued to lose some weight and now she's down here. Now, interestingly, at this point in time, this is now in 2022, because when she first came in 2018, we actually had the discussion of surgery because surgery was indicated for her, meaning, her BMI and comorbidity would have indicated surgery. And she was entertaining it because she had complications of obesity that were significant and she wanted to get rid of those complications. She walked out of the surgeon's office. She went to see the surgeon. She walked out. I happened to be in the same clinic because we worked in the same space. And she says to me, she goes, you know what, Dr. Fitch, I'm going to do it without surgery. And she was very excited that, I said, I don't know what happened because I sent her in and she was all, had already decided that surgery was a good tool and this, that, and the other. So we entertained this treatment. And the reason I say this is that now that she's down here at this normal BMI and she's, feeling great, she wishes she would have had surgery because she doesn't want to take medication anymore. Now, that's an interesting dilemma. We can't predict the future. Now, at the same time, she recognizes there are risks of surgery, et cetera. And she's certainly very happy with her treatment and her outcome. But again, it's something we have to continually talk to patients about because it does mean now that she is going to be on medication for potentially a long time for her to be able to maintain that weight loss. And that future is yet to come. But at least today, that's what we think. So these are our current FDA approved medications on the left, and those medications we tend to use off-label for treatment on the right. And that's just because the label is not indicated for some of these for obesity. But again, we recognize that they are effective treatments. And this is what I want to sort of highlight. Is if you look at this 20% weight loss category down here, this is what we call categorical weight loss. 5, 10, 15, 20, and 30% weight loss. We don't have a lot of data for some of these, which is why they're blank, because a lot of times in the older times, people did not publish the actual categorical weight loss. They would only publish average weight loss. But what we're really wanting to look at is what's called categorical weight loss, because what that tells a patient is, what are my odds of achieving that weight loss with that intervention, right, in a shared decision-making fashion? If you look at intensive lifestyle modification here from good studies from Weight Watchers and other intensive behavioral therapy programs, about 10% of people are able to get a 20% weight loss with intensive lifestyle intervention. That's not because the other 90% of people aren't good at doing weight loss. I mean, aren't good at doing lifestyle changes in their diet. That's because that treatment intervention that's how effective it is for obesity treatment. It's just not as effective as we would like it to be for obesity treatment if you're only doing a lifestyle modification by itself. Now, for the 10% of people that are able to lose 20% of their weight, it's great because they don't have to have surgery. They don't need medication. So it's important to do lifestyle modification to identify those 10%. Otherwise, those 10% wouldn't get a chance to do that. So it's not like we just put medications on first or surgery on first. But the idea is that this is the effectiveness of that intervention. This is also the effectiveness only at 1 year. Most of these studies are only about 1 year, except for surgery. If you look at this surgery column here at 10 years, you can see that 72% of people, even at 10 years later, have still maintained a greater than 20% weight loss with surgery. That's just the level of efficacy that treatment intervention provides. You can see why there's been a big more uptake of medication as it relates to semaglutide coming to the market. Because if you look at the semaglutide column here, almost 40% of people were able to get into that 20% weight loss category. Where our older medications, if you look at phentermine topiramate here, about 15% of people are able to get into that category. So you can see we doubled, almost tripled the amount of people able to get into that 20% weight loss category with this newer generation, highly effective anti-obesity pharmacotherapy. Now, the reason why tirzepatide, which is currently on the market for diabetes treatment, is very exciting is that you can see here that 63% of people are getting into the 20% weight loss category with tirzepatide. So we've now doubled again the amount of people able to get into this category with that medication. If you even look up here at the 5 to 10% weight loss categories, you can see with lifestyle intervention, about 48% of people are able to get 5% weight loss. It still means 51% of people didn't, right? And so that's where even adding medication for lower weight losses is still significantly better than doing a lifestyle modification alone if those patients aren't able to reach that goal. You can see also in red here where when you combine intensive behavioral therapy, combine lifestyle, which is one of the reasons we're talking here today with Dr. Freitz and myself together, is that when you combine lifestyle modification with medication, you get even more efficacy. Here with liraglutide, you have 63% of people in that 5% category. And now when you combine it with intensive behavioral therapy, you get 74%. Same even here with bupropion naltrexone, which is a less effective medication, as you can see. But when you combine it, you get even greater efficacy. So that's why this holistic, treatment as a chronic disease is so important. And in the interest of time, and I'll share these slides, but in the interest of time, this is just a very large overview of where all the different drugs, make their interactions as it relates to both the peripheral and central regulation of appetite. And this is just to highlight that many patients cancel appointments out of weight-related anxiety, experience weight-related stigma, even from clinicians in the office, and especially in women. They do report weight as a barrier to care, which is one of the reasons why we've created Known Well. As we're choosing medication, how do we choose medication, right? Unfortunately, the first thing we have to look at is it covered by insurance today? And that's a huge barrier. Then we have to assess for contraindications and risks, assess for double benefits, meaning the patient may have migraines as well as needing to have weight reduction. And so they might, benefit from something like topiramate, for example, or bupropion for depression, as well as weight loss. And then does the patient have diabetes, prediabetes, insulin resistance, or metabolic syndrome? Because again, that might be another reason why we're choosing a different class of medications, such as a GLP-1 metformin or SGLT2. And so again, just to sort of, end things here, I just wanted to highlight this is the data around tirzepatide from the pivotal study SURMOUNT-1. SURMOUNT-2 was just released a few days ago. SURMOUNT-2 was done in patients with diabetes. So the weight loss was less in the patients with diabetes. We know that in people with diabetes, they have less weight loss when they're treated for obesity. But here you can see, this is where you can see this 20% weight loss category, almost 63% of people getting into that 20% weight loss category with this intervention. And so in summary, I think we all have to create this obesity care plan for our patients, diagnose obesity, prescribe a nutritional plan, a lifestyle intervention, prescribe an activity goal, because, lifestyle is the pillar, the fundamental, base of all that we do. Then prescribe medication if indicated, evaluate for surgery if indicated, and also if patients have had surgery, evaluate their anatomy to make sure things are still intact. And then arrange for follow-up as most important, because again, just saying up to the patient to do, sort of follow-up is not okay. We need to say this is a chronic disease, we need follow-up. And then considering remote monitoring, chronic disease management, and especially I think with the advent of artificial intelligence, which has really hit the stage here running, it's really going to help us to do health coaching and other types of chronic management better. I'll end on this just to update you all that we have a journal at the Obesity Medicine Association called the Obesity Pillars. And we have multiple clinical practice statements. This is the one written on anti-obesity medications, but we have a nutritional clinical practice statement, a physical activity, behavioral, all sorts of clinical practice statements, including a recent announcement, not a clinical practice statement, but a consensus statement on compounded peptides, and recommending that compounded peptides not be used in clinical practice because of concerns around safety and efficacy. So everybody, this Obesity Pillars is free to everyone. It's an open access journal, so you do not have to be a member of OMA in order to read it, and you can find it at the Elsevier website if you Google Obesity Pillars. Thank you so much.
Wow, that was fantastic. Thank you, Dr. Fitch. How about a round of applause for Dr. Fitch? We have some great questions coming in. Please keep them coming. We will do Q&A at the end because we have another star speaker for you. And this is just what a lineup. This is a record attendance too. We have 180 people on this Zoom call. And again, please keep the questions coming. Our second star speaker is my dear friend, Dr. Beth Freites. And she has such a long resume that if I read her entire bio, it'll take up the remaining time that we have. So I'll try to talk quick. Beth Freites, MD, is a trained physiatrist and a health and wellness coach with expertise in lifestyle medicine. She's an award-winning teacher at the Harvard Medical School, where she is an assistant clinical professor. She is one of the first fellows of the ACLM, the American College of Lifestyle Medicine, and she's a pioneer in lifestyle medicine. She developed a College of Lifestyle Medicine curriculum at the Harvard Extension School in 2014, and it is still one of the most well-received courses offered at Harvard. She was voted president of ACLM in August 2020 and currently serves as president. It's a 2-year term from 2022 to 2024. She has authored a lifestyle medicine syllabus, which can be downloaded through the ACLM website to serve as a template for other instructors and professors. In addition, Dr. Freites co-authored the Lifestyle Medicine Handbook, an introduction to the power of healthy habits, which was ranked in the top 20 by Book Authority for medical books released in 2018. To accompany the syllabus and handbook, she also co-created Lifestyle Medicine 101, a full college curriculum with 12 weeks of PowerPoints and a teacher's manual, which is free and accessible through the ACLM website. And I have used it. It is fantastic. In addition, Dr. Freites co-authored the Teen Lifestyle Medicine Handbook, published in October of 2020, which when paired with the teen curriculum consisting of a teacher's manual and the 12 PowerPoint decks can be used to teach and empower middle school and high school students to adopt healthy habits. She's all about teaching all the way from middle school to medical school. As Director of Wellness Programming at the Stroke Institute for Research and Recovery at the Spaulding Rehabilitation Hospital, a Harvard Medical School affiliate, Dr. Fritz has created and implemented a 12-step wellness program, paving the path to wellness for patients and providers. Most recently, she co-authored the book Paving the Path to Wellness workbook, a guide to thriving with a healthy body, peaceful mind, and joyful heart. As of the fall of 2020, she serves as the Director of Lifestyle Medicine and Wellness for the Department of Surgery at Mass General Hospital. In addition, she has her own lifestyle medicine consulting and coaching practice where she sees patients one-on-one and in groups. And the only way that she can do all this is that she has 31 hours in a day. So please welcome Dr. Beth Sprates.
Oh, thank you so much. It is such an honor and privilege to be here sharing information with you today. And I'm going to share some slides. I want to save time for questions. So I'm going to try to, let's see, I'm going to get through this so that we'll be able to have conversation. I will share these slides. So if I pass through a slide and you're wishing that I spend a little more time on it, you'll be able to see it at your own pace and your own time later. I'm delighted to share with you some information actually about well-being that we're going to need for ourselves. Because by the way, we're also patients. I know everyone realizes that. We're patients and we're also clinicians, healthcare providers, physicians, nurses, a whole host of individuals are with us today, and we honor that. And we do remember that we're also patients. So this is CME. I'm on the scientific advisory board of Jenny Craig, medical advisory board of clearing.com. I have my own private practice. And the big disclosure, though, some of you who know me know this, is that my own father was overweight, overworked, overstressed at the age of 52 and had a very unhealthy lifestyle and suffered a heart attack and stroke, leaving him paralyzed on the left side. And I was 18 at that time. And at that time, I changed majors at Harvard from economics to psychology and biology, became pre-med, dove into how mental stress impacts the heart, how our diet impacts our endothelial cells. That was my study at Stanford Medical School, and then came back to MGH as doing an internship in internal medicine, and then completed my residency in physical medicine and rehab at Spaulding Rehab Hospital, where I remain at Harvard Medical School. But this is my passion since I was 18, and that was a few years ago. So delighted to share information with you and to build upon what my dear friend Angela has already shared. I'd like to, in this amount of time I have, perhaps 10 more minutes or so, I want to give you some new insights on healthy living and wellness. And I'd like to provide you with some strategies that could enhance your lifestyle medicine interventions, because it is about intensity, our interventions, even in lifestyle medicine. It's what was the diet? What was the healthy eating pattern you prescribed? And how intensively did the patient, the person, follow that? Did they also adopt the 6 pillars? Did they also use exercise? Did they also enhance their sleep so that they could sleep 7 to 9 hours, which is the recommendation? What were they doing? What was that lifestyle medicine intervention? And how can we improve it? So that's what we're doing at the American College of Lifestyle Medicine. And we know with intense interventions, we can get greater change. So I'm going to share with you, yes, the 6 pillars. Many of you are very familiar with those, but I'd like to give you the plus from the Paving the Path to Wellness program work I've done. We'll talk a little about attitudes, timeouts, energy management, purpose, a sense of purpose, and how important that is for our patients, for ourselves, and a variety, goal setting, how to set goals, and investigations. I will, of course, evidence-based lifestyle medicine. We're going to look at research in these areas. I have 10 minutes, so it's going to be a tour de force. Okay, and what we're really all looking for: patients, providers, people who have a healthy weight, people who have a BMI in the overweight or people who have a BMI in the obese category, what we all are looking for is to not just survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style. This is Maya Angelou, you know that. And that's what we all really want. And for ourselves, we know that this is a tough time for all, patients, providers alike. And I'm talking about wellness and well-being here. And for us to practice at the top of our game, we need to feel well. So I'm going to ask you all to think about yourselves throughout this presentation, these next 10 minutes, and think about your patients. If you haven't seen this article, I'd like to draw your attention to it. The American Journal of Medicine, 2019, Shapiro and colleagues looking at the wellness hierarchy for physicians with the basics here, having access to bathrooms, having no depression or anxiety, being free of substance use, right? And then safety, feeling safe, the patients are safe. Then respect, this is such a critical part of well-being. Basic level of mutual respect and inclusion at work, outside in our communities. And then appreciation. I am noticed and appreciated. I'm connected. This social connection pillar is critical. And then healing patients and contributing, that's the top of all of what we want to do. We all want to do this together, collaboratively, not in silos, but together. And when you have time, autonomy, and resources, then you can really think creatively, and you can really start your journey and of transcendence and helping others to reach their best selves. So the paving the path to wellness, yes, it is the 6 pillars of lifestyle medicine. You'll see them clearly. For the body, physical activity, nutrition, and sleep. For the peaceful mind, the stress resiliency. But I'm going to add in a bit about attitude and timeouts. And then the joyful heart. This sense of purpose is critical. And our energy management, not just our time management, but I am going to be savvy and be watching my time so we have time for questions. And then social support. How important this is. You all coming together. This today, us being here, the 186 of us together today. This is creating connections and social support. Angela and I are already working together so that we can make a difference in this world, in the area of managing weight. And then action steps. We all need these, our patients and we as providers alike. Goal setting, investigations, trying new things, experimenting, and then adding variety into our lives. So I do have a questionnaire. Harvard Health helped me put this Paving the Path to Wellness questionnaire for patients together. And when I run my group visits and my one-on-one visits, I do give pre and post the Paving the Path to Wellness questionnaire, and it is free and downloadable. Paving the Path to Wellness, it's also in the book, Paving the Path to Wellness. All proceeds of that book go to a nonprofit called Paving Wellness. And this way we can figure out where we are. Where are we starting? And where do we want to go? That's how we make progress. We understand where we are, and then we know where we want to go. Our patients alike, where are they starting with their physical activity? Where was they starting with their sleep, with their stress management? And then where do they want to go? This helps give them some roadmap. Now, when we think about wellness, this is beyond disease. This is wellness. Think about that for yourself. What does wellness mean to you? There are many different definitions, many. A process, a way of life. I love. It's a healthy body, a peaceful mind, and a joyful heart. And this is what I work towards for clinicians that I counsel, patients that I counsel, patients with a BMI in the healthy range, patients with a BMI in the overweight range. We're working towards this overall goal. It requires a focus on healthy habits, a dedication to growth. It's a state of being beyond lack of disease, beyond that neutral point. John Travis's work, critical work since 1972. We may be in neutral point where there is no disease. There are no signs and symptoms of disease. This is where we medically have been trained to get people out of trouble with signs and symptoms of disease. And then with lifestyle medicine, we use this. We use the 6 pillars to help people reverse their conditions. When used intensively, we can do this with some conditions, to treat conditions, to prevent conditions. And I will argue It is lifestyle medicine that can help get us to high level wellness, where we have awareness, education, and growth. So we need exercise. We know we need this. We learn this in our medical school training, in our healthcare professional training. We learn more and more each day, though. That's the exciting part. We know that it helps our endothelial cells. It reduces our clotting. It can increase our HDL, which is hard to do even with medication. Exercise itself is like 11 medicines, as I am sure you're well aware of, and it helps with body weight control, as we've talked about. What people don't always appreciate is it helps the mind so much. You are aware it releases dopamine, which keeps us motivated, focused, and learning. You're aware that it's like an antidepressant. Research studies have shown us it increases serotonin, just like an antidepressant can. It releases endorphins, norepinephrine, and something most people aren't aware of, BDNF, brain-derived neurotrophic factor. So we can increase the number of neurons in our brain. How? With exercise. Amazing. And it can change the morphology of our brain, increase our hippocampus. People are worried about diabetes. They're worried about cardiovascular disease, our number one killer. They're worried about dementia. They're worried about obesity. Exercise can help us in all of these conditions, all of them. And interestingly enough, there are so many fun ways that we can go from cell to community, because we're talking about one-on-one with lifestyle medicine. We're talking about working with people one-on-one, but we also use the social ecological model of change. And we look at their surroundings, their family structure, their work life, their neighborhood. Are there grocery stores that sell fresh produce? Are there safe places for a bicycle? Maybe not big enough for a conference bike, but what is the environment around the person? When we think about physical activity, is it safe outside? By the way, this is what I would like for my birthday. If anyone is looking, I've looked at this and I've wanted this for so long. Imagine if we had conferences on a bike like this, how different it would be. I do hold walking meetings, and that is one way that we could get movement into our day. Speaking specifically about weight today, irisin, which was really discovered about a decade ago, it's a myokine. Our muscles release it when we exercise. We're learning more and more about it. When I taught this at the extension school in 2014, people said, oh, does irisin really exist? Yes, it really exists. In 2023, not only do we know it exists, we know that it impacts many organs, including our brain, and it is involved with appetite regulation. More importantly, we need to think about people's attitudes. We need to use positivity. Barbara Fredrickson's work, we know this, and you're familiar with Marty Seligman's work on positive psychology. When we use positivity, appreciative inquiry, we help patients so that they can find creative solutions to their issues, their problems, things that are holding them back. I want to also introduce to you this idea of an amygdala flare, where a patient may feel a threat, the amygdala flares, and then they're just reacting emotionally. And this may lead people into emotional eating. This may lead people into disagreements, maybe even losing their job, because people, when they respond only with their amygdala, their prefrontal cortex is not in control. Prefrontal cortex, that's our CEO of our brain, that tells us, oh, that conversation is a tricky one. We probably shouldn't have it with the chairman of our department right now. No, the amygdala flare just gets a threat and fires. One thing that we know is sleep. If you are sleep deprived, you're 30% more likely to have an amygdala flare. If you have enough sleep, you will be able to avoid these amygdala flares. So these pillars of lifestyle medicine are interrelated and very important to take seriously. We must consider all of them. Now, here's something we should talk about. Let's have a little variety, have a little fun. We want to have a happy brain, dopamine, our reward system, our motivation. How do we do that? Celebrate small success. That's setting SMART goals and meeting them. Endorphins, laugh a little, exercise, even stretching can release endorphins. Oxytocin, hug each other, pet a dog, socialize, get a massage, serotonin, expressing pride, not arrogance, but pride in a job well done. That gives us a little serotonin, as does exercise. And notice that influence. Laugh, have some fun. Investigations. Try new things. Be open-minded. You are the experimenter and you're the subject. This is the key, and have your patients feel the same. Maybe they want to try hula hooping for physical activity. Maybe they want to try hiking. Who knows? Let them experiment and enjoy that. Now, with nutrition, we've talked a lot about this in lifestyle medicine. We think about the whole food, plant predominant diet. And in this recent study from March 2023, multiple dietary patterns were examined. And what were the guidelines from all these different sources? I'm sharing these slides with you for you to examine more clearly. But everything in the green is that these guidelines say include more of this, include more of legumes, fruits, vegetables, nuts, include more. And what are they saying to exclude in the red? What are they saying? Red meat, exclude. Processed meat, refined grains, fatty meat. Same thing here with the include more on the green, exclude in the red. Sugar sweetened beverages, salt, alcohol. Just more data for you to understand and for you to help your patients understand the value of fruits and vegetables and these antioxidants in them, as well as the fiber that's important to lower the chance of type 2 diabetes, heart disease, stroke, colon cancer, and to manage weight. Why? Because we get the short chain fatty acids. And what do those do? Here's a study for you to examine. Dietary fibers, gut microbiome ferments it. You get the short chain fatty acids. They go to the L cell. They increase the GLP-1, the PPY, the proglucagon, the L cell proliferation with the regulation of energy metabolism, glucose metabolism, lipid metabolism, inflammation, immunity, and this helps prevent cancer. Goals, setting goals. If you don't know Tal Ben-Shahar, please do look him up. This is a fabulous book. We need to think about the goals our patients are setting and how these goals are connected to pursuits that connect with their overall purpose and vision in life. And this is an article I'll draw your attention to. You have values and vision, priorities and purpose for yourself. Your patients have this. When you create the SMART goals, make sure they're connected to their purpose, their vision for themselves in life. And then stress, ever so important. You know that your hippocampus can increase with exercise. Well, stress can decrease the size of the hippocampus. So we know that stress resiliency is critical. And I'm going to share with you 14 evidence-based ways to reduce stress, because stress eating is a major, major issue. Mindful eating is what we want to turn to. If everyone took 10 deep breaths, got into rest and digest before they ate their food, they could fully absorb their nutrients. So get out in nature, exercise, mindfulness-based stress reduction, meditation, play with a pet, take vacation, take deep breaths. Here's some more for you to evaluate in the literature. Music, practice yoga, laugh, expressive writing, chewing gum. And here's a hard one, but important, checking email less. Hold on. Checking your email less frequently. And this is an example of stress reduction. What do you do when this happens to you? In the middle of a presentation, you forge forward and you keep going. You need a little time out to get yourself organized. And here we go. That's an important part of paving the path to wellness, taking time outs. And that means taking your vacations. You know, people, in order to regulate what they're doing, and that includes eating, sometimes we need a little time between stimulus and response. So there's something that triggers us. Let's take some time, take some deep breaths, and then let's respond. This is also how we avoid that amygdala flare. Moving on, remember, I thought of it while riding my bicycle on a break was theory of relativity with Albert Einstein. So energy management, we talk about time management, but I'm going to wind this up so we have some questions, time for questions. Energy management is key. It's key. And it has a lot to do with all the 6 pillars. Focusing on healthy foods. Many people are low in magnesium. They don't feel they have the energy to exercise. They don't feel they have the energy to do their work. Thinking of consuming nuts that are full of magnesium, making sure they get their sleep. That's why these pillars are essential for a lifestyle medicine intervention to work. We need to look at all of the 6 pillars, not just 1 or 2. It's not exercise more, eat less. No, that's not a lifestyle medicine intervention. And that's often what's studied. Lifestyle intervention includes all of the 6 pillars. Sometimes we get energized by being with friends or being out in nature, or petting our dog and playing and laughing can energize us. There's different types of energy. You'll have the slides to evaluate these more carefully. There's physical energy, emotional energy, mental energy, spiritual energy. We need all these types of energy to stay motivated and to be able to be well. We need a purpose in life, everyone, physicians, patients alike. What is our purpose? What are we striving for? Viktor Frankl, his book, Man's Search for Meaning, I recommend it to you, to all of your patients and your loved ones. Everyone has his own specific vocation or mission in life. Everyone must carry out a concrete assignment that demands fulfillment. Therein he cannot be replaced, nor can his life be repeated. Thus, everyone's task is unique as his specific opportunity to implement it. It's critical that we think about our purpose. Sleep. You can't have a lifestyle medicine intervention if you haven't addressed sleep. Sleep deprivation is associated with high blood pressure, heart disease, obesity, and diabetes. So if the intervention hasn't helped people address their sleep, then it's not a high level, high quality lifestyle medicine intervention. So you must read what these lifestyle medicine interventions entail. You know about sleep hygiene, earplugs. Did you know you need to keep your bedroom cool? Optimal spot is 67 degrees because a drop in core body temperature is a signal for sleep. Also, no screens before bed, 2 to 3 hours before bed, because blue wavelength light gets to the retina, affects the pineal gland, and the pineal gland will shut the release of melatonin down. So in order to sleep well, we need to follow sleep hygiene from lifestyle medicine. And if it is not being addressed in the intervention, it is not a comprehensive, intensive lifestyle medicine intervention. Okay, and lastly, social connection. So important. If we are not addressing how lonely a person feels, or if they are socially connected, we are not doing a full-on comprehensive lifestyle medicine intervention. And we know low quality connections are associated with development of our #1 killer, cardiovascular disease, recurrent heart attack, atherosclerosis, high blood pressure, cancer, delayed cancer recovery, and slower wound healing. Recently, very recently, just now, in March 2023, 8 hours of social isolation, looking at psychological and physiological variables, was compared to 8 hours of food deprivation. And guess what? Social isolation led to lowered self-reported energetic arousal and heightened fatigue, which was comparable to food deprivation. We have to take social connection seriously. If it's a lifestyle intervention, it must address social connection to be a comprehensive, intensive intervention. And that just leaves me with one of the best presents we can give people is social connection. My dear old mom, she lived with me. And the one thing she wanted when she was 86, the only thing she wanted for Mother's Day, which is coming up. So here's a great present. And for any other present giving occasion, she wanted lunch with her 40-year-old, her friendships of 40 years with her 2 dear friends who were also 89. It's a critical part of healthy living. It's a critical part of well-being. And that's it, paving the path to wellness. I tried to give you some new ideas, and I know we are limited with time, so I'll stop sharing here. Thank you for being with me on that journey through the 6 pillars plus. Thank you.
Thank you so much. Thank you, Beth, and a huge round of applause for both of our speakers. Thank you. Wow. There's just so much food for thought here, and we have lots of good questions coming in. Please keep them coming, and we'll try to get to as many of them as we can. Some of them are specifically for Angela, but I think most of them we would love to hear from both of you coming from different perspectives. Malti, did you want to say something?
Yeah, great talk. Both speakers did a wonderful job. And I have a question from Dr. Fitch that a lot of, in my practice, I have been seeing a lot of my patients are coming with, like, they're seeing some online doctors who are prescribing semaglutide for them, and they don't even qualify for the BMI. And I don't think they're getting much of lifestyle interventions. Any thoughts or words how to address that with the patient in the clinic?
Yeah, I think it's challenging. I mean, we really advocate for medication use for appropriate people that have, appropriate reasons to utilize medication management, right? As Dr. Freight said, right? I mean, everything should be, on this sort of continuum of care relative to the burden or the intensity of their disease, right? And so if they don't have metabolic disease or they don't have a complication and they don't meet the BMI criteria, it currently would not be recommended to have a treatment with any medication for that matter, whether it be semaglutide or phentermine topiramate or any other, type of medication. So I do think it's an opportunity to sort of go back to the education piece, right? As Dr. Freight started that nice discussion of, with Nelson Mandela, or was that was Uma that had Nelson Mandela. Yeah, thank you. Dr. Kaduri, who had I loved that, right? The education piece.
That's
And
my
go back
favorite
to
slide.
I love that slide. Yes. Go back to that slide and say, this really is an opportunity to educate, because people are desperate for, help in managing the world, right? The obesogenic environment we live in. And the other piece that, hopefully some people are getting actual semaglutide, which is, a prescription at the pharmacy. But again, as I mentioned, someone asked a question about compounded semaglutide. We do not recommend it. Any compounded products. It's important to talk to your patients about what they're getting. If they're getting something that's in a vial that they have to reconstitute or they have to inject, if it's not coming, in sort of the standard packaging from pharmaceutical, the standard pens, right? These drugs come in pens that you use to inject. That we would not recommend it, because those drugs are coming from unknown sources and unknown quality of their integrity, and we don't know the effects of them on humans. So it's the largest uncontrolled, unconsented human experiment going on right now in the country, unfortunately.
Thank you.
Dr. Ravi Kohli, President.
Yeah, hi. Both of you were tremendous, amazing speakers, especially at the last speaker, Dr. Freitas. That was a very passionate and very poetic presentation. You actually inspired me to do a small poem here, or just a small snippet. Let me read it. Choose health, not chase wealth. Seek wellness and not be sick of illness. Become grateful, not be greedy and grumpy. Show compassion, not sow conflict. Develop empathy, not dwell in envy. And stay humble, not be full of hubris. So I'm a psychiatrist, so, so I had to come up with something in that line. At the same time, I also came up with my theme of my year as the president of AAPI, true and total wellness. True and total health is the well-being of the mind, body, and spirit. So if you may, let me do my proclamation here on behalf of AAPI at the encouragement of Dr. Uma. Let me show my screen and read the proclamation. Okay, I hope you can see it. Okay, let me read the proclamation. 1 second. Okay. American Association of Physicians of Indian Origin proclamation, whereas the greatest responsibility we have as physicians is to promote the health and wellness and prevent the illness and alleviate the suffering. And whereas lifestyle choices are the most important determinants of health and wellness, poor lifestyle choices exacerbate public health problems of our populations in the 21st century globally. Whereas unhealthy habits lead to worsen broad range of serious health problems such as diabetes, hypertension, high cholesterol, heart disease, strokes, and risk for some cancer with bad outcome. If this trend continues, next generation will have a lower quality of life and shorter lifespan. Whereas unhealthy life choices and associated health risks cause significant cost to families, increase our healthcare expenses, and adversely affect our economies. And whereas AAPI Obesity Committee has previously started a movement on December 12th of the year 2012 to educate and empower individuals by conducting health and obesity walkathons walkathons and wear yellow events to bring awareness to the obesity pandemic and promote healthy lifestyle choices. Whereas yellow signifies energy, motivation, hope, optimism, joy, and happiness to help individuals lead healthy lifestyles. And whereas in the USA and the world, we know that when we come together and work on challenges, we make progress and solve problems and build healthier communities and generations. Now, therefore, hereby, during this health education webinar on lifestyle medicine, obesity medicine, on April 30th in the year of 2023, we rededicate ourselves with determination and make lifestyle medicine proclamation that healthy lifestyle leads to health and wellness to one and all. So true and total health is the wellness of mind, body, and spirit. Signed by Ravi Kohli, President AAPI, Dr. Uma Koduri, Chair of AAPI Lifestyle Committee. Thank you.
Thank you, Dr. Kohli. That's fantastic.
That was inspired by Uma Garu, who always has some creative ideas of encouraging, bringing some energy and motivation and into the education as well as empowerment. Thank you, Uma Garu.
Thank you.
Can you
Beautiful.
share that poem with everyone? That was amazing, really deep and thoughtful. Can you share that in some way, the poem?
You need to unmute, please.
I'll post it on the chat box so people can, yeah. It just popped up on my mind how to say it. Thank you. Yeah.
Beautiful. So I think we have about 20 minutes left and we have 25 questions. I know some of them have been answered already, but let's do about a minute or two per answer. So we'll go sort of rapid fire style. The first one is on screen time. We could, maybe both of you could talk about screen time. We didn't really hear about that too much. We heard about blue light and sleep. Could we elaborate on screen time? Whoever wants to go first. We need a buzzer.
Okay, so I'll start, and then Angela, I'm sure will follow up with some more information. So yes, so we now know that it's screen time, in that the blue wavelength light, as you've already heard, will impact our sleep. But most of the time when we are on the screen, we are sitting. Most of the time. Very few people are on an exercise stationary bike when they are watching television or using their computer. Angela and I are, and others probably on the line are also on their stationary bike, or I'm often on a exercise ball. But others, most people, are in front of the computer and they're sitting. So sedentary physiology itself, really since 2015, we've understood the pathology of sedentary physiology, meaning we increase our triglycerides when we are sedentary. Lipoprotein lipase goes down. It also has an impact on HDL, reducing it. And sedentary time physiology disrupts our blood glucose control. This is why the American Diabetes Association asks people, especially if you have prediabetes or diabetes, to stand every half hour. Everyone should be standing every hour. Mind you, wait, are we on the hour? Yes, oops, okay. So we should probably all stand. I'm just standing and walking a little bit, just because every hour we're meant to stand, so we don't fall into that sedentary physiology. And all it takes is standing, even 5 minutes. I mean, this is awkward, so I'm going to sit down, but later I will stand and walk around, probably walk my dog, even though it's raining here in Boston today. At any rate, so with screen time often comes sedentary time. And again, sedentary behavior is a risk factor for our number one killer, heart disease. So it's essential that we consider screen time when we are counseling any patient, asking how much time do you sit? How much time are you on the screen? And then when are you in front of a screen? Now that's because of sleep and the important pillar of sleep. May I also put a plug for sleep, just to say, American Heart Association has now put it into its essential 8. For years and years, American Heart Association had essential Seven areas to focus on. You know them: high blood pressure, cholesterol, exercise, diet. Then they added sleep in April 2022, a year ago. So screen time is essential for these reasons and many more. And I'll let Angela tell you the more.
No, I think you covered it. That was great. I agree.
Beautiful. Moving along, and I think Angela talked about this a little bit, but someone specifically asking about communicating. When you say that someone is overweight or obese, they might get offended and then give you a bad review saying the doctor was rude. How do we address this? I know you talked about it a little bit.
Yeah, I think, we have to recognize that for many people, coming into the doctor, getting weighed on a scale, seeing the number go up, up, every year, and experiencing the fact that they have a lot of times been trying to lose weight, they've been trying these things and they haven't been helpful, that is traumatizing in a way. If you can imagine, if you are, somebody who started having struggles with obesity at the age of 10 or 12, and now, over and over, people just say, well, you just got to eat better. You just got to exercise more. You just got to sleep better. You got to stop using that screen, and again, I'm not saying we don't help people to do those things, but over and over again, if we're not able to provide the level of intensity of intervention that they need, as Dr. Freight said, right? This is something where, unfortunately, a lot of our interventions have not been, potentially the data I showed of lifestyle intervention as it relates to treating obesity, which is, a complex disease that has so many, intertwining things, including genetics and other factors, right? That the efficacy potentially of lifestyle interventions is that we haven't had a good enough intensity, or we're not delivering them in a way that that patients are able to uptake, right? But anyway, over and over again, you're coming into the office and saying, well, you should just do this, do this, do this. And then like the patient's like, I can't do that. And that's not, hasn't helped me. And then it just keeps getting worse, right? So that experience is traumatizing in a way when that happens year over year and the same outcome happens, which is that they don't get the results that they want. So, that's where I think, recognizing that, hey, I recognize that you've been trying these things and you haven't potentially gotten what the desired outcome. So how can we help change that? What do you need to help make that better? Whether that's more intensive health coaching or more intensive support, or maybe it's, medication, right? That's going to help somebody, just like we have with hypertension or other diseases, right? That's the key.
Yeah,
Thank you.
I totally agree with Angela. And I would say, I love the way Angela frames that, and how you talk to the patient is so important. And with lifestyle medicine, as we know, so much of it is the magic sauce. It's a communication. What we train in, what we learn about is trans-theoretical model of change, meeting the person where they are, using motivational interviewing. And so what I tend to do now is, if there's a number that we're talking about and it has to do with the number in the scale, or really any number, I say, I see the number, I say, so there's this number. Okay, it could be weight, it could be hemoglobin A1C, it could be cholesterol. Here's this number. And then what I say is, what do you think of that? Because mind you, if the number is 200 pounds and they say, oh my gosh, that's terrific. I was 252 years ago. I can't believe it. Well, that's a whole different conversation, isn't it? Then if it's the number's 200, they say, oh, I had no idea. I was 170 last year. I can't believe it's gone up that high. This helps direct the conversation. You ask them what they think about that number, because then you can dance with them. That's coaching, right? It's dancing rather than wrestling. Then you can dance with them in a comfortable way.
Beautiful. Thank you. So the next question was about compounded semaglutide, and I think Angela already said, don't do it. Use the real stuff from the pharmacy.
Yeah, I mean, the key is it's not coming, the source ingredient. There's nothing about compounding. I mean, I'm not against compounding as a whole, it plays an important role in our pharmaceutical delivery of things, right? I mean, we've compounded things for a long time, like especially creams or other topical things that people can't put together, or there's patients who have allergies to some of the other inert ingredients that are in medication. So having a place where they can put generic drugs, even so much as, there are compounders who will put bupropion and naltrexone together, generic bupropion, generic naltrexone together into one pill so that patients don't have to take 2 pills, right? I mean, that's totally something that is acceptable because they're taking sourced FDA approved generic products and mixing them together. In the case of compounded peptides, there are no source generic FDA approved base products. The base product is not coming from a regulated source. And these compounders, we have no idea where this base product is coming from. And it could be made in containers that contain mercury or lead or some other, unknown contaminant in them. And that's the part that's really, challenging.
Thank you. The next question, I think, is a really juicy one, and I'd love for Dr. Coley to chime in on it as well. It's about drug-induced obesity. The question is about antipsychotic medication, but I would add to that, other iatrogenic obesity, whether it's from glipizide, insulin, beta blockers, right? So many of the bread and butter medications that we use. And I think you still have your hand up, Dr. Coley, so maybe you could.
Yeah, I'll load it. So actually, I just want, I have to leave soon. So I want to just, I'm a psychiatrist and Dr. Gazula was a psychiatrist. So a lot of our very effective drugs are unfortunately also come with the burden of heavy side effects of weight gain. So of course, some of our drugs like Wellbutrin is also helpful for weight loss, but there are other drugs that are harmful for with weight gain. So that's a challenge, and hopefully, and fortunately, some of the newer options are a little bit better as for the effects on the weight. So, but like you always, the problem is that the devil is in the detail. A lot of times we are kind of prevented from using the best options for our patient due to the prior authorization problem. So that is something we all have to really, as an organizational, professional organization, we have to fight this prior authorization barrier that are really preventing good healthcare delivery to our patient. So that's a challenge we all have to really fight together. And also, I have to leave. I had a meeting at 12 o'clock, so I'll leave. But before I leave, if you don't mind, I want to give virtual plaques to our 2 speakers. So I will share the screen and do that right now, if you don't mind, just to break in. Okay, thank you. So here is our first plaque to Dr. Beth Frates, MD, FACLM, DIP, ABLM, for your outstanding contribution to the field of obesity style medicine. And we welcome you as the member of our AAPI Distinguished Speakers Club, signed by Dr. Srini Gangasani, who just joined from his event from the temple, and who is a cardiologist from Georgia, and myself, Ravi Kohli, psychiatrist here from Pittsburgh, president of AAPI. Thank you, Dr. Pratis. And next plaque goes to Dr. Angela Fitch, MD, FACP, FOMA, and for your outstanding contribution to the field of obesity and lifestyle medicine. And we also welcome you to our AAPI Distinguished Speakers Club, signed by Dr. Srini Gangasani, chair of AAPI CME committee, and Dr. Ravi Kohli, myself. Thank you very much. And before I leave, I just want to do another plug for our convention coming up in Philadelphia. Coming up in Philadelphia from July 6th to 9th. Please sign up. We will have a lot of lifestyle medicine track presentations like this, and it will be inspiring you to choose better, healthy lifestyle habits as well as for yourself and your patient. So registration is going on. We have a lot of registrants coming through, but we welcome you all to join as well. Thank you very much, and I'll be leaving in another 5 minutes to a local chapter meeting here in Bethlehem, PA, Lehigh Valley Hospital, Lehigh Valley area, welcoming them all to the AAPI convention. And it's a fantastic presentation. I'm glad I was able to join. And from here on, take over, Pankaj. And I didn't want to call Dr. Wiz because it'll be confusing. There are two Dr. Wiz here.
Yeah.
I'll say, call you Pankaj and I'll call you Malti. Hi, Malti. And I'll take off here. Thank you, Srini, for joining. And thank you, AAPI office, for arranging everything today.
Thank you. Thank you, Dr. Kohli. Yeah, we have a lot of questions still to go through.
Yeah.
Malti, I see that you have your hand up.
Yes, I have a question. Yeah, I have a question for Dr. Fritz. I've been trying to put it in my practice for my patients who needing weight loss. So what are your thoughts about intermittent fasting or time restricted eating for these patients?
Yeah.
So I do think, I think, Beth, you could comment too. I mean, from a lifestyle, I mean, I think we don't know enough about intermittent fasting from a standpoint of its effect on human metabolism directly or health. Like we have a lot of insights that it potentially has benefits as it relates to mitochondria and cell apoptosis and all sorts of interesting biochemical potentially interactions with our metabolism. But I mean, that most of that data comes from animals and other types of research. So we don't have a lot of human data, unfortunately. I think if it fits with the patient, it's great, right? And from a weight management standpoint, it hasn't been shown to produce a lot of obesity treatment, right? Or weight loss, because again, people also have to reduce their caloric intake overall if they're going to, but if it helps to do that, because it gives them more structure. Anytime we have more structure in the world that we live in, I mean, the world we live in is naturally producing, by 2030, 50% of the population in America is predicted to have a BMI greater than 30. So again, this is the environment we naturally live in as humans, is producing excess adiposity. Right? So you go out there, you just live naturally, and that's what you get out of it. So we have to create a different structure for everybody, for all of us and for all of our patients that we live into that almost is not sort of natural. And that's the challenge, that's why we're here, having this discussion. And how do we help people to do that, right? And so if intermittent fasting will help them, to live into a more structured lifestyle, I do think it definitely is something to consider, Now, I will say one caveat that from the data from animals and from some early human data is because Walter Lago at, I think he's at UCSF, someone, Pankaj can correct me if you know where.
He's in Southern California, I think USC.
USC, thank you. So he, has done a lot of research on intermittent fasting as it relates to aging and cancer and other types of diseases. And, the data shows that you should fast more in the evening, right? So again, the other challenge we have in America is that we also don't, sort of do intermittent fasting right. Like we tend to fast, from, in the nighttime to all day. Like we fast in the all day and then we eat more at night. And ideally we want to fast more in the afternoon, evening, and eat more in the morning, right? So ideally you eat between 8 and sort of, 3 o'clock in the afternoon, if you're looking at sort of, best health outcomes, and then fast for the rest of the time.
Wonderful. Thank you. That was a really good question, Malti. Thank you for asking and a great answer. The next one is a really juicy one too. It's from a pediatrician, and it's about the fact that diet management and obesity treatment is incomplete, and we have a broken system because people need to learn early during infancy, childhood, middle school, and beyond. And I think this would be a really good question for Beth, who's done a lot of work with children. And before she answers, I want to acknowledge Dr. Srini Gangasani, who's joined. He's the chair of the CME committee and also part of the executive team of AAPI this year as treasurer. Hi, Srini.
Hi, Pankaj. Yeah, sorry, everyone. I couldn't make it to the whole meeting just because it's the first CME meeting I missed in the whole year. I had some puja yajna. I had to do it at the temple. So we just finished it. So thank you, Uma Koduri, for putting this whole thing together, and Pankaj moderating the session, and Dr. Malti Vij for bringing the speakers. I think between Uma and Malti and Pankaj, I know this is a great talk. I think it's very useful for lifestyle medicine. I'm a cardiologist. I'm hoping that with all the changes with the lifestyle medicine, our business hopefully will go down a lot less stents, last stent bypasses in the future. But I'm definitely going to go back and look at the recording so that I can listen to what the things were said. And for everybody else too, we want to give it to other people to just listen to AAPI website, has all the information, and the whole video will be available for everybody to see. Thank you, Pankaj. Appreciate it. And the speakers, I think I really appreciate taking your time. Dr. Beth and Dr. Angela, I think you've done a probably wonderful job. I really appreciate it from the bottom of my heart for doing this. Thank you.
Thank you, Srini. Let's want to talk about childhood education.
Okay, sure. Thank you so much. First of all, sorry, I thought you said Dr. Frates with the last question, but I'm glad, Angela, I'm glad you took that because you answered it so beautifully. And I completely agree with you on the intermittent fasting. May I just add just a little bit on that, which is, so with patients that come to me and they say that they'd like to try intermittent fasting, I say, okay, well, tell me how you plan to do it. And if it's safe, I say, sure. Remember, investigations. Let them try this experiment. And I will say that sometimes they do have weight loss, right? After 4 weeks, they will have weight loss, but I will share this. And I think Angela was getting to this, and this is what we're going to see in the studies. It's hard to adhere to that for a very long time. This is why then I'm following them for another month, 2 months, and they're no longer doing intermittent fasting. So perhaps in the short term, they're going to see some weight loss with this because, as Angela said, because you're boxing yourself in, you're putting some guardrails in, some speed bumps in to your eating, and you're actually reducing calories in the end, perhaps. And then I will just add, if we don't eat after 8, right? If we don't eat after 8, if we just all put that in, and by the way, I have Greek descent, right? My grandparents came from Greece. This is just the way we grew up. You eat during the day at 8, we stop eating, and we're not eating after 8. We're not eating until we wake up in the morning. So basically that's a 12-hour fast, but I didn't know I was doing that my whole life, right? I didn't realize that's actually, but circadian rhythm, so much to that, right? Okay, back to so teaching this to the middle schoolers. So I'm a mom, they're 23 and 21, my 2 boys now. But when they were in middle school, I was floored with the fact that they were not learning about stress, resilience, about healthy eating. I couldn't believe it because these are our future leaders. These are our children. They're the future leaders of the world. If they become doctors, lawyers, business people, they need to know this. So we made that team lifestyle medicine book and curriculum, hoping that teachers in middle school will teach it. So I tried it myself and I taught the students. I went in to the middle school locally. Guess what? They loved it. They loved learning about deep breathing. I gave them multiple options, autonomy, right? Everyone loves autonomy. Which did you like better? 4-7-8 breathing, box breathing. One of them even raised their hand and said, my therapist taught me this. Thank you, Dr. Frates. You know, this is what my therapist told me to do. The therapist, the middle schooler is, again, if you need that, they should be getting therapy. I'm hopeful that if we can get this into all middle schools, we can help bring this type of living with the 6 pillars into their day-to-day and into their existence and make it the natural fit. Now we have to change the environment. I'm with Angela. We are in an obesogenic environment, a stressed environment. We have to change the environment. While doing that, we can help them have tools so they can reduce stress in healthy ways. And I am very hopeful by making this available and free. I sent an email to our mayor here in Boston, Mayor Wu, asking her to adopt it. I haven't heard back yet. It was a couple of weeks ago. I'll try again. But I think if we actually get this into our system, our education system, and it's going to take a lot of trying and emailing. But I do think if we can do this, it will be a service to our young people and our leaders, our future leaders.
Thank you. Excellent. The next question is about telemedicine in the management of obesity, and they're asking about RPM, remote physiological monitor. And I would expand that into, the role of Fitbits and smart scales and Apple Watch and all the different devices that are now available where we can self-monitor. Have you
Yeah,
seen any
I think
kind of-
it's gonna take off. From a standpoint of Apple just announced that in the iPhone 17 they're going to have a AI health coach. So we'll see how that works out. But AI powered health coach. So as standard, in your Apple phone, right, it's going to come with this standard ability to have this, artificial intelligence coach you on some of your SMART goals. So again, I think the future is really going to leverage a lot more of this technology in that positive direction versus right now, all the technology has been leveraged to the other side, like watch more screens, watch more TikTok. So I do feel like there's a shift, at least technologically, hopefully, because of all the work we've been doing, as clinicians trying to advocate for change in this space. But again, with remote patient monitoring, so telemedicine is obesity medicine, as well as I would assume, as well as doing the lifestyle coaching too, is very deliverable via telemedicine because you don't have to necessarily, touch people or examine people or, that sort of thing. I mean, obviously it's important to do that, as a whole long term, for various chronic disease management, but the idea of delivering some of this via telemedicine has been key, I think, during the pandemic. And then hopefully will continue. We need to make a lot of different changes to telemedicine law, for example. I know some large health systems here in Boston are now cutting back on the ability to offer telemedicine because it's not reimbursed at the same level that it's reimbursed for in person. So for example, a lot of insurance companies prior to the pandemic would only pay 80%, 80% of the total cost. So they'll pay you 100% if you do it in person. They'll pay you 80% if you do it via telemedicine, which is ridiculous. I mean, if the person drives in and spends an hour of their very limited day, coming into the office, and I just sit there and give them the same, same medical advice I give them if I'm sitting in the office versus sitting on the screen like this. I mean, that shouldn't be 80% less, right? Just because we're on telemedicine, but that's happening in the country. And so we do have to, unfortunately, I think, advocate for the fact that this is that the access to care is an issue, and that this is a very deliverable specialty in what we're doing, and very deliverable disease modifying abilities, and in order to encourage changes at the at the institutional regulatory level, et cetera, in order to advocate for coverage and treatment.
Thank you. Thank you. I know we're coming to the end of our time, and we want to be very, very grateful, express our heartfelt gratitude to our speakers, and let everybody get on with their day. If we can, I just have one last question. Is that possible? I know Dr. Freites might have to go soon. So maybe we can close with a question for Dr. Freites about virtual health coaches.
Yes.
Any resources for virtual health coaches?
Okay, that's a great question. Virtual health coaches resources. I always go to the National Board of Health and Wellness Coaching for all information on health and well-being coaches. So that would be my first suggestion, to go to the National Board of Health and Wellness Coaches. And personally, when we're talking about virtual visits, Angela did that beautifully. I would share that since COVID, I have been doing, I want to say 99% of my work still virtually. And I was very hesitant, being a hands-on, want to hug you kind of person. I was resistant to this idea that we could do this online, definitely, until I did it. We had funding from SAMU organization to run group visits in lifestyle medicine for stroke survivors online, 3 a week for 6 weeks. And we got virtually the same results virtually as we had in person. So we have been doing at Spalding Rehab Hospital, and now with Mass General, we're actually holding group visits with physicians for lifestyle interventions. So again, this is why I always say physicians are also patients. At any rate, the results are remarkable with online. So coaching online, we're going to find out what the research tells us. You know, I'm research and data driven. So I'm going to want to see some research in this, some large scale studies. And I haven't seen that quite yet, but I think we will see, and I'll look to those. But right now, what I'm seeing in observational reports, in case demonstration reports in the literature, is that people are getting really good results with online coaching and group coaching, one-on-one coaching and group coaching. So that's what I know of right now, but I'm anxious and very interested to see what the literature shows and what we see in it.
Beautiful. Thank you.
There is one company that I know of that delivers, you know, that you can contract with, that will deliver virtual health coaching, you know, for, like, you can, as a physician, you can say, I want to work with these people and they're going to deliver my coaching for me, right? Because instead of hiring my own coaches, you know, so again, you know, I think there are these opportunities coming forward where there may be some of this, you know, very reputable and evidence-based type of companies coming forward that would, you know, sort of help to manage that coaching platform, that coaching, you know, that coaching delivery.
Excellent. Thank you, Dr. Freites. Thank you, Dr. Fitch, for two fantastic presentations. We do have some unanswered questions, and there's a lot of requests for the PowerPoint deck. So Dr. Gangasani, if we can make sure that people get their questions answered, if both the speakers would agree to maybe look at this later. And then if there's a way to get the PowerPoint deck, that would be with the permission of the speakers. I know we put the recording, but if the speakers are gracious enough to share their decks, at least 8 or 9 requests for that.
I can just quickly answer one of the questions. I peeked in at the Q&A because I want to make sure I got answers to the questions. One was about magnesium, and it said, well, you know, why check magnesium, or what your kidneys are helping definitely maintain your magnesium. Certainly the kidneys, when they're functioning well, can help us maintain, but we need to have consumption. And if we're just having fast food, we are not likely to be having the green leafy vegetables and the nuts that are providing the magnesium that we need. So unfortunately, people are on the standard American diet, which could be French fries and potato chips and cookies, and they will not be getting their magnesium in that way. So this is why a lot of people are walking around magnesium deficient. And do we have to test everyone? No, I'm not advocating for that, but I am advocating for a whole food, plant predominant eating pattern, which will supply us with enough magnesium, nutrients, and vitamins and minerals, such that we don't need to take supplements of any kind. So that would be the take home point for that one.
And I'll do one really quick too before we go. I know we got to go, but we have a question about pediatrics, and it is so phentermine topiramate, as the drug Qsymia, is approved for children down to the age of 12, and semaglutide is also approved for children down to the age of 12. Phentermine in and of itself, as a standalone drug, is approved down to the age of 16. We have setmelanotide, which is a specific drug targeted towards people with genetic defects relative to obesity, that's approved for the age down to 6. And then we have tirzepatide. The question was actually towards tirzepatide. Tirzepatide is not yet approved for obesity treatment. It's expected to be approved in the next 6 months. But when it does, it'll initially be approved for adults because the studies have only been done in adults. Tirzepatide has not been approved yet in pediatrics. So right now it's liraglutide is approved as Saxenda for obesity treatment for pediatrics, but also now semaglutide, because it's once a week, which is so much better than kids having to take an injection every day.
Beautiful.
Okay.
Big thanks to both of our speakers. Again, thank you for staying over time. We still have other questions to be answered, but we'll keep working on those. And lastly, Dr. Gangasani will say a word and we can close.
Yeah, thank you everyone for the wonderful CME today. I think if you guys can, if the speakers can share the deck, we'll put it under the video recording of the program. If not, I think if they can answer the questions through the chat box, that would be great too. I think one more CME left for next month in June. So that'll be end of the as academic year for us. And then the new program starts in July, the new CME chair. I appreciate everybody to participate in a Sunday morning program. I think Uma, Pankaj, Malti, I think they've done a wonderful job as the moderators. Thank you again. See you.
Thank you,
next
Dr.
month.
Yeah. Thank you,
Bye-bye.
Dr.
Yeah, thank you.
Thank you, Dr.
Dr.
Fritz. Thank you,
Fitch
Fritz.
and Dr. Fitch and Dr. Fritz, we would like to collaborate with you and work on this project in the future. You know,
Happy
we would
to
love
do
to
so.
work with you both. You know,
Thank you.
thank you.
Thank
Ma,
you
I
for
wore my
including
yellow.
us.
Ma, I wore my yellow for obesity
I
campaign.
know. I mean, Pankaj did that. You know, I wanted to tell everyone, but I thought they'll think, oh, it's too much to ask. So I did. Thank you all very much.
Thank you, Ma. Thank you, Pankaj.
Thank
Thank
you.
you. That's thanks. Bye.